All right. Thank you very much, and I too appreciate the opportunity to come and speak to you. I just wanted to know a little bit more about the audience. So how many of you actually are involved in any way with pulmonary rehabilitation currently? So a fair number that actually, front row excluded. So there are some rehabilitation programs that are in Israel right now? Yeah. That's correct? Yeah. Okay. And then the whole idea is that it's only in major cities? Is that? So most of them?
More than 20 programs ongoing.
More than 20 programs, okay. All right, that's phenomenal then. Okay. And the rest of you, how many are interested in trying to start one in your area? Okay. How many are trying to start a pulmonary rehabilitation program in your area? So a group of those as well, which is one of the reasons. How many of you who have the pulmonary rehab programs actually use integrated care with the primary care as well as the pulmonologist and kind of, all of the different people in as an integrated care model? So some people do. All right, sorry. My faculty disclosures, again, they haven't changed for those of you that came yesterday. I didn't get a new grant overnight, unfortunately. So why shift the focus in management from acute to chronic care? That's one of the questions we're going to be answering. Can everybody hear okay?
Perfect.
Okay. We're going to talk about the components of the chronic care model. How many have heard of the chronic care model? Okay, so a handful, and so we've got some work to do with introducing, and you may recognize it once you see it. And then how can chronic care be applied to a patient through pulmonary rehab? So first of all, why do we need chronic care? We know that patients with all chronic diseases have a lot of unmet needs. This happens to be with end-stage lung disease in general. 38% of all caregivers had unmet needs based on this survey. And then when you look at it, 54% of caregivers that provide day-to-day care for their loved ones with end-stage lung disease have unmet needs. And so we're not doing a very good job just in general, at least in most cultures, of meeting the needs of people, of caregivers. They had trouble with actual physical care of the patients, symptom control. I mean, it's horrible to be around somebody, and those that come into your clinic and are severely short of breath, we're around them for the 10 or 15 minute visit, but to have a loved one that's that symptomatic all the time, it just wears on you. It's really frustrating. Also, they don't really have a lot of information about the future course of the disease, and part of that is because for any individual patient, we don't know the course of the disease, right? I mean, we all have people with FEV1s of 20% are predicted that maybe live for years and years and years, and somebody else with an FEV1 of 45% are predicted dies within 6 months. And so we don't know, we can't predict real well, but at least what are the types of things that happen? And then better emotional support. So we're going to start with Mr. Martin. I've changed his name, but this was an actual patient of mine early in my fellowship, and I wasn't always interested in COPD. I actually didn't particularly like patients with COPD. I didn't like taking care of them because I, like many, didn't feel like there was much you could do for them. Then I started doing a little bit of research in it, reluctantly. I wanted to do lung transplantation, but that project fell through, and so my mentor said, "You're going to do COPD." Bummer. So, but I actually did it, and now they're my favorite group of patients to take care of because of patients like this. He has very severe COPD, on supplemental oxygen, but only wears it when he's short of breath because he didn't want to get addicted to it. Have you heard that before?
Yeah.
Okay, all right. So a little bit of education there is the key. He uses 26 to 30 puffs of albuterol, similar to your salbutamol here, and so he's using a ton of it per day. He's confused about his other medicines. He knows that he's got a bunch of inhalers, and he kind of uses them as needed, and he kind of needs them, and so some of them he's using 3 times a day, the ones that are supposed to be once a day, and he was just all confused about it. Still smokes a pack a day. He reports depression and panic attacks. And in fact, his wife, when he came in, they were about to get a divorce. He truly felt like he was going to be dead in about 6 months, 3 to 6 months. He was actually severely disabled, having palpitations with all the albuterol, but he was so short of breath he didn't know what to do. He also had hypertension, angina, and congestive heart failure, and so he was pretty sick to begin with. He had 2 admissions for an acute exacerbation of COPD as well as CHF, because sometimes it's really hard to tell, especially when they come in with heart failure and COPD, wheezing and that sort of stuff, within the last year. So is his case rare? Well, let me ask you, have you seen people like this that are pretty end stage, out of control, that sort of thing? So less than 50% of patients with major chronic illnesses receive accepted treatments. And most of them don't have adequate control. And this is a Confronting COPD survey. I took the US data, but it was done kind of worldwide, but I couldn't find specific data for Israel. Look at this, 70%. Bronchodilators, the mainstay of care for COPD, only 70% were on bronchodilators. Still a huge percentage smoking. Suboptimal control was a large percent. And despite influenza being a grade A recommendation, really a high recommendation on all the guidelines, less than 60% actually had received the influenza vaccine. This was a survey of patients with self-reported physician-diagnosed COPD, about 1,000 of them. 41% reported a prior hospitalization, and over 60% reported significant shortness of breath. 10%, not surprisingly, knew their FEV1. Surprisingly to me, these were actually, many of them had spirometry. So I said yesterday in the US, less than half of the patients that have repeated visits by clinicians for COPD, less than half have had spirometry. I suspect it's even lower here, since I hear that primary care don't really do much spirometry here. And so compare that to almost 80% that knew their blood pressure. And even, the good cholesterol, the bad cholesterol, even though that's relatively complicated, 37% knew their cholesterol. So we're not doing a very good job of, quote, know your numbers sort of a thing. And I'm not sure that it's really that important for patients to exactly know what their FEV1 is, but to know that they have significant obstruction to airflow or airflow limitation, I think is important. 72% were taking any sort of med for COPD, despite a lot of them having moderate to severe dyspnea, whereas 87% with hypertension were taking some medicine. So again, our cardiology colleagues, they're my idols because they do a much better job. They have more money and that sort of thing, but they do a much better job with educating the patients. So there's this whole thing by the Institute of Medicine. Between the healthcare we have and the care we could have lies not just a gap, but a chasm, a huge, massive chasm that we're trying to jump over, and one slippery slope and we may end up falling straight down. So the whole goal is, how do we close that gap? What's responsible for this big, giant drop-off and hole between what we want and what we have? So who's responsible? Is it non-compliant patients? You think it's predominantly the patients? Probably a lot of it's patients. It may not be because they're stubborn and they just don't want to do it. It may be that they don't know what to do. Do you think it's us? We're actually aware of the guidelines by survey data, but we don't do them, at least predominantly not in primary care. But we're all busy. You see how many patients in a day? How long do you actually have to spend talking with your patients and really getting them to understand, unless you have patient educators? Are those available here?
Partially.
Partially. So a little bit available. So some people have some educators, other people don't. How well equipped are medical assistants or nurses in your office to teach about COPD? So it goes up and down. And that's the same in the US. It really is. It's the same in the US. So is it a system problem? And this is what I'd argue. So if you're trying to stack the boxes and you have this whole ramp and and everything is going on. So the system is the issue, and so current systems cannot do the job. And this is what the Institute of Medicine said. The only way that we can, trying harder just alone, each one of us kind of spinning our wheels doesn't really work. Changing systems is what we have to do, and I think that's why we're here, and I think that's what the initiative that all of Israel is doing is phenomenal, and I support you any way that I can with that. So acute versus chronic care. Acute, they come in with symptoms, we treat them, we send them on their way, wait until they come back with symptoms, and most of us don't do this. Most of us see the patients every 3 or 6 months or whatever, and we're pretty good about doing that. But the problem is there are a lot of things that go in between there. Whereas the chronic, you really try to promote health, self-management, that sort of thing. Try to prevent complications, reduce exacerbations, and most importantly to the payers, as well as to us, decrease the healthcare utilization. So the autocratic or reactive system in the acute care problem is we want to fix what's there. And I mean, in school, we're taught something's broken, you fix it. But the problem is that a lot of times, things are broken long before you recognize that they're broken. And so what we want to try to do is have a long-term vision. What is it that we're trying to do long-term? We want to try to promote autonomy as opposed to just telling the patients, take your medicine, that sort of thing. They have to want to take the medicine. And we're going to do an exercise here in a minute to show you that there are different ways that people learn. So when we do have educators and we do have time to actually teach them, then I want to at least show you that people learn differently. So this is the chronic care model. You have the community, resources, and policies in the healthcare system, and see how they overlap here. You've got self-management, support, delivery system design, decision support, and the clinical information systems. And I'm going to define each one of these. The bottom line is you want a patient who's activated, who's involved. And you want a practice team that's involved, and you want interaction between the two. Because if you just have a really motivated patient, but a system that doesn't support that, it's not going to work. It's like them working hard. So this whole changing systems is important. Self-management education, it's a process. You want to actually go through intervention elements. And so the style of teaching is changing from traditional didactic. Me standing up here and telling you what I'm going to say, you get maybe, if I surveyed you and actually created a test, let's say 6 months from now, you may remember 5% of what I said, maybe 10, okay? And that's even pretty optimistic for me. So I want to show you that there are ways to actually teach that gets the patient involved. What I have learned is if I teach it to somebody else, if I actively engage in something, we retain about 50%. If I teach it, I retain 90%. So getting patients to teach each other in ways, and it hasn't been implemented a lot, but getting them to teach is a way to get them actively involved and activated. So the key to self-management is continual patient and health professional communication and access. So, does everybody have a pen or a pencil? Yes? Okay. I would like you to stand up. This is actually in Alaska. I took this picture, like the first picture. And so, not in San Antonio, Texas, where I'm from. So I would like you to stand up. And I'd like you to get your pen and your book, and we're going to write down letters A, B, or C to the questions. Over here on the wall is an A, at the very back is a B, and over here is a C, and you're going to vote with your feet. So you're going to walk, and you're going to vote with your feet. Do not write down the first question, but after this, I'm going to have you put 1, 2, 3, 4, 5, up to 12. So this is your first question. When I go on vacation, I like A, beaches, walk over there. B, mountains, walk over there. C, cities, and watch the courts. So once we're back there, then we don't have to worry about the courts so much. So C is over to the right-hand side. So don't write this one down. We're going to write after this. Okay, quickly move to your area. All right, so we got a lot of folks that like the mountains. Okay, so this is the first one that you're going to write down. You're going to write question 1, and then you're going to write A, B, and C to this question. When I try to concentrate, A, I grow distracted by clutter or movement, and I notice things around me that others don't notice. B, I get distracted by sounds, and I attempt to control the amount and type of noise around me. Or C, I become distracted by commotion, and I tend to retreat inside myself. So quickly move, A, B, or C, quickly move to your areas. And then just write down A, B, or C on your thing. So you guys are still A? Y'all are still A? You guys are B? And you're C? Okay, kind of stay where you are. So write question number 1, A, B, or C. Question number 2, when I visualize, I see vivid, detailed pictures in my thoughts. I think in voices and sounds, or I can see images in my thoughts that involve movement. A, B, or C. Move to your areas and write down question number 2 and write down the one that you have. We have quite a few more in C than oftentimes. Okay, next question 3. When I talk with others, and these are not mutually exclusive, you have to choose only one, but I realize that many of these may apply. So choose just one though. So when I talk with others, I find it difficult to listen very long. I enjoy listening, or I get impatient to talk myself. I gesture and communicate with my hands. A, B, or C, move quickly. You're staying, huh? Are you C? Okay. Number 4. Okay, number 4. When I contact people, A, I prefer face-to-face meetings. B, I prefer speaking on the telephone for serious conversations. Or C, I prefer to interact while walking or participating in some activity. A, B, or C? All right. Number 5. When I see an acquaintance, A, I forget names but remember faces, and I tend to replay where we met for the first time. B, I know people's names and I can usually quote what we discussed. Or C, I remember what we did together and I may almost feel our time together. A, B, or C? Many are staying put, huh? Okay. Question 6, when I relax, I watch TV, see a movie, go to a movie, see a play. B, I listen to the radio, play music, or talk with a friend. C, I play sports, make crafts, or build something with my hands. A little bit of movement here. Okay. Number 7, there are 12 total, so we're over halfway through now. When I read, I like descriptive examples and I may pause to imagine the scene. B, I enjoy the narrative most and I can almost hear the characters talk. C, I prefer action-oriented stories but do not often read for pleasure. A, B, or C? Again, have some movement. All right. When I spell, I envision the word in my mind or imagine what the word looks like when written. B, I sound out the word, sometimes aloud, and tend to recall rules about letter order or symbol order. C, I get a feel for the word by writing it out or pretending to type it. Okay. Number 9, when I do something new, I seek out demonstrations, pictures, or diagrams. B, I want verbal and written instructions and to talk it over with somebody. Or C, I jump right in and try it, keep trying, and try different approaches. So many people are just kind of staying some movement again. Number 10, 3 more, this one and 2 more. When I assemble an object, very similar, I look at the picture first, then maybe read the directions. B, I read the directions or I talk aloud as I work. Or C, I usually ignore the directions, figure it out as I go along. In the U.S., almost all the guys are on C. I don't know how it is here. My husband's not good for reading directions. He jumps right in. And then we have 7 extra parts at the end. And it's like, well, okay. Number 11, when I interpret someone's mood, I examine facial expressions. B, I rely on listening to tone of voice. Or C, I focus on body language. A, B, or C? Okay. Last one. When I teach other people, I show them. B, I tell them write it out or I ask them a series of questions. Or C, I demonstrate how it's done and then ask them to try. Once you finish this one, you can move back to your seat, and then we're going to tally up how many A's, how many B's, how many C's you have. Again, watch the chords. All right. How many have the most A's? Or have y'all not been able to tally yet? Let's give you just a minute. Okay, so most A's. How many are mostly B's? So a fair number. And C's? Okay, so if you're A, you are a visual learner, predominantly. If you're B, you're an auditory learner. And C is a kinesthetic, means you do stuff with your hands. Okay? How many of you had at least 2 in another category other than just 1? So you had at least 2 categories with at least 2. So many of you. So it shows that you're not predominantly one style. You're predominantly one style, but you learn other ways as well. And so visual learners observe demonstrations, they read, they interact with computer simulations, and you can use slides, photos, and handouts. So things like this. Auditory learners do well with lectures and also with like the CD that we're going to give, the auditory, you can just listen to the lectures. Kinesthetic learners do best by what I just did. Make you move and sit and walk to where you are. So demonstration, hands-on simulation, props, things like that are very helpful for kinesthetic learners. So I just did this, one, to wake you up. I know you were just at a break, but after the break you get kind of sleepy. So 1, I did that for that. But 2, just to show you that we tend to teach how we learn. So if you are trying to explain this to your medical assistant or nurse or whoever is going to teach the patient about an inhaler technique or whatever, it may be very helpful to assess how people learn. You know, do you like to listen to stuff? Do you like to watch it? Or do you like to get your hands on it? And it may be that it's multiple ways. So, education topics in COPD that have been proven effective include smoking cessation, breathing strategies that were talked about a little bit before, proper use of medications, and that is critical. I talked about that yesterday, but I just can't tell you how many times. And this particular patient was on one of the inhalers that's the capsule that you have to push, and he was inhaling, but he never pushed the capsule, so he never punctured the capsule, so he wasn't getting any of that medicine. So it's one of those things. Exercise, that's the big thing that we're talking about here. And anxiety and panic control. The SOS, stopping their thoughts and things like that. SOS is just kind of a short stopping, shortness of breath sort of a thing. And the whole idea is that when they get short of breath, how many have been truly distant? Like truly, absolutely short of breath, like thought you were going to die? Anybody? So a couple of people. It's terrifying. Even if you've never had anxiety or depression before that, you often get anxiety after you have that, and our patients have that a lot. The ones that need more evidence, the eating properly, the leisure is really important. The calling us when they're having trouble, and the action plan for early treating exacerbation. It really, I think there's a lot of data out there. There are some conflicting studies, but I think we're getting more and more in general that that's a very important part of a pulmonary rehabilitation program as well. So that was self-management. Delivery system design is really where you have a whole team with defined roles. You have planned visits based on evidence medicine. So the whole idea of giving long-acting bronchodilators to patients with COPD, if they're not on a long-acting bronchodilator and we're not following the evidence, then that's a problem. So that's really important. You provide advanced access to care. So they have the availability. Anybody have this right now, a nurse link or a nurse line that patients can call 24/7 if they're in trouble, or is your access to care the emergency department? Mostly emergency department. And I think that's very common. That to set up, again, I'm giving you the ideal. Where you want to be in 20 years, okay? So where you want to start is with what you have now, and then eventually you want to move to more of an ideal comprehensive program. And so you want to provide advanced access to care, if at all possible, with the ability to have some sort of a nursing link. It doesn't have to be that you have to see them, but do you have an electronic medical record here?
Yeah, most of us do.
Most of you do. And so if you have somebody that's on call that has access to that, that knows that this is somebody that's a frequent exacerbator, and when they call, they're really sick and they do need to come in, versus somebody that's just anxious and needs a little reassurance. And again, there are issues with that about how to train and that sort of thing, but that's what we're talking about with decision support. I mean, with delivery system design. Decision support is really the guidelines. So the delivery system is a little bit about the guidelines, but this is really about using the evidence supported by proven education and treatment modalities. You want to integrate specialty care with primary care. So if your patient has severe comorbidities or multiple morbidities, primary care hate it when I say comorbidities because they don't think that COPD is like the most common morbidity and the other ones are co. So for them, they say multiple morbidities, kind of they're all equal. They all have big problems. Because some people, the diabetes is much worse than the COPD. So it's kind of multiple morbidities. Reminder and fail-safe systems. How many of you actually remember every single patient that comes into your office to ask if they're a smoker, to advise them to quit, in flu season give them the flu shot? How many of you would be able to do that on your own without any reminders or anything else? My hand is definitely down because I get busy and I start seeing patients, and some of those routine things, unless I have a checklist or I have reminders, it gets really tough. Even though I know that's what, and they leave and I'm like, bummer, forgot that one. So get my nurse to call them back or whatever. So what we've done is try to put in systems where the reminders, with your electronic medical system, does it pop up reminders for you? Does it pop up 500 of them so you, okay, click, and you don't even read them anymore? So that's a problem. The VA, the Veterans Administration, has that as well. We already talked about this, but it really is a huge problem with the multiple morbidities, looking for these. If you have your patient with a hip fracture, they're not going to be able to do a whole lot with pulmonary rehabilitation except maybe the upper extremity type thing. That's where physical therapy really comes into play and can be a nice tie-in to pulmonary rehabilitation. But if they're doing great and they're on their home maintenance plan and then they have a hip fracture, that's a big deal. So that's why we say that chronic oral steroids in patients with COPD, I'm not talking about COPD in severe asthma too, but in patients with just COPD, you know based on the guidelines, there's no role for oral systemic steroids in just stable COPD, even those with frequent exacerbations. But the problem is if they do have an asthmatic component, then it may be reasonable to put them on steroids, but it does cause a lot of osteoporosis and things like that. Clinical information systems is a registry. So if you have electronic medical records, you're already above the curve on that, which is great. So some of ours, we have a lot of electronic medical systems in the States, but none of them talk. And so that's a problem when you can't get access to the information. But that's the reminders and the feedback. The feedback is critical. Because if you get reminders and you click okay, and then you get a report at the end of the week, you clicked okay, but 7 of your patients didn't get an influenza vaccine that needed it. And it's not that they just refused, that's one thing. But when they actually didn't get it, and we didn't ask for them if they wanted to get it. And then facilitate care planning for individuals and the whole population. That's the whole idea of getting groups of patients together and coming up with systems for them. This was a study that we did. It was a meta-analysis, and I think somebody mentioned yesterday, unless you have a lot of resources, I will never do this again. Not by myself. It is a ton of work. And what we did was we looked at, basically based on the chronic care model, how many studies had just one intervention alone versus multiple components. And on ED, emergency department, and unscheduled visits, you can see that the relative risk was way significantly low. So it lowered the risk of emergency department visits for those that implemented multiple components of the chronic care model. We excluded pulmonary rehabilitation programs in this systematic review because, one, there were a couple of systematic reviews in pulmonary rehab that clearly showed benefit. And so that's one of the things that we did. So this is just implementing the chronic care model. I would argue strongly that they should be merged, that this should be a part of your pulmonary rehabilitation program, if at all possible. You can see that for as far as hospitalization, one component, so if you just do teaching alone or if you just implement the guidelines, didn't make a difference. That's where you really have to implement multiple things to reduce hospitalization. What do the payers care about? Cost. Yeah, money. And hospitalization drives the most of the cost. So if you can show that your program reduces hospitalization, that's why I really think the greatest thing to do is target those that are the highest risk, and then you can kind of expand out after that. So as far as length of stay, it was shorter in the intervention group based on a couple of the studies. And the cost. So what about this? This was done in Canada, actually, and looked at previously hospitalized patients. 14 patients per case manager. The cost was just under 4,000 Canadian dollars, and versus a savings of about 3,300. That's when it was 14. But basically, if you expand that out, so they had a very intensive system because they were trying it out and just figuring this out. Now I know Jean Bourbeau and his group has actually expanded it out a lot so that there are many more patients per case manager. Then you have a lot more savings per patient. And now I think, from what I understand, they target, you guys correct me, they target not only inpatients, but they actually target basically most of the patients that have exacerbations. Is that correct?
Yeah, the ratio of around 4 to 1.
I'm sorry, it's not savings here. It's the cost of this versus this. So there was a little bit of savings. So this should be cost, I'm sorry. So cost of $3,700 for the patients without versus $3,300 for the patients with the case manager. So there's a little bit of savings, but not a lot. And then if you expand it out, then there's a lot of savings. I'm sorry, what were y'all going to say?
Oh, I was saying the ratio is about one case manager can take about 40 patients.
So 1 to 40 now. And I know each province has different systems now, and I know it's not universally accepted. What about yours in Saskatchewan?
We do hospital and a bit of lower intensity. We have a 1 for 65 patients.
So 1 for 65 patients if they haven't been hospitalized so much.
I'd rather have 1 to 40.
Yeah, absolutely. I'd rather have 1 to 40, but it's about money. And so existing study results can be used to identify potentially cost savings programs. And so it really is all about cost. But unfortunately, for the patients, or fortunately for the patients, these actually do improve a lot of other things, and particularly with pulmonary rehabilitation, it improves a lot, as you've seen. Primary care time. So can we do this? These are the 10 top diseases in the U.S. Total hours per workday, assuming you have a routine load of 12 patients. 3.5 hours per day. If everyone with these conditions, not all of them, but if they have basically a condition and they're stable, it's 3.5 hours a day for 12 patients in the morning, 12 patients in the afternoon. If you have one uncontrolled disease, or 3 of them, let's say 3 uncontrolled diseases, you add 10.6 hours per day. If you have acute problems, so you have that acute illness that comes in, that's an additional 4.6 hours per day. So I don't know how many hours you guys work. I know it's more than 8 hours, but 14, 15, 16, 17, 18 hours a day, is that about average? So maybe a little bit less than that, but it's a lot. And this is primary care. And so for them to be expected to then do other things on top of this is really hard. But what if we took this uncontrolled and these acute problems and reduced that so that we're dealing more with the stable patients? Then that may be very helpful to them. Shared care versus primary care only. We know that it's important. Overall, there were 20 studies, and this was a Cochrane analysis. They did respiratory diseases, asthma, COPD, basically lung function. There was no change in one of them. It was improved in the other. But you know, pulmonary rehabilitation really doesn't, for the most part, change the lung function. Doesn't change your arterial blood gas. So that's not what you're trying to do. Now, they feel better, they have reduced exacerbations and all that, but it doesn't really change their lung function unless they weren't on inhalers and you get them on standard of care. So then it'll change. But admissions, no change in reduced respiratory in one, but the cost was reduced in some of them. So overall, 20 studies, there wasn't a lot of positive that was going on. But again, these were very heterogeneous group, and it did show at least some that the collaboration is what's really important. And I asked yesterday how many people actually have, how many primary care read your notes when you send them back. And it's kind of the same with us. I mean, they kind of read the bottom line to it, but they don't really read all the details of what you want them to do. So where do we go from here? We need to try to change systems, which is why we're here. We need to have a step-by-step guide and how to improve tools. We need to measure it. And it's actually been implemented. The Institute for Healthcare Improvement has actually implemented it for critical care, CHF, diabetes, and asthma. Clearly shown improved outcomes in those diseases. Sid Brayman is doing this ACCP chronic care model for COPD. He was in Rhode Island. I think that it's kind of still kind of going without him so much because he's moved now. But he's got a template for how to do this. And so I think that's very important. So Mr. Martin got in a clinical registry. It says that he needs an influenza vaccine, and I didn't just click right through it to ignore it. He's enrolled in smoking cessation. Actually, with him, he was so stressed and so everything. He thought he was going to die, so he just wanted to continue smoking. But when I really talked to him and explained that I thought we could help him, we reduced his albuterol to as needed as opposed to 30 puffs a day. His anxiety and tachycardia got better. He actually did go to a pulmonary rehabilitation program and markedly improved in symptoms. He started wearing his oxygen because his saturation was like 76, 78% on room air. So I explained to him he's not going to get addicted to it, that it's very important for him to wear his oxygen and it improves his mortality and all of that. He's actually wasn't using his medicines correctly, and so we fixed that. But he came back, and guess what? Next time, a month later, he was doing the same thing again. So he forgot. And so we have to ongoing continue to assess it. We screened him for osteoporosis, and actually this guy's FEV1 was about 14, 16% of predicted. And he was severe when I started. Once we got him on his meds, he came up to about 22, 24% of predicted. And this was when I was a fellow that I saw him. And he survived. He had a hip fracture. He was on chronic oral steroids. We got him off that. He basically had a hip fracture about 11 years after I saw him. And he just passed away at about 19 years after I initially saw him. And I saw him at restaurants. He was wearing his oxygen. He was functional again. He was still with his wife. And so it was a really big success. So in summary, I want to encourage you to shift the care from acute to chronic care. And the challenge is really to integrate pulmonary rehabilitation programs and engage primary care in the process, because by itself, it won't really help. And I'm sorry, with our activity, we didn't really leave time for questions, but I am available at lunch if you have questions. So, thanks.
Thank you very much.